All right, we're going to talk about the crash cart today. Each crash cart has this list that talks about what's in the crash cart and talks a little bit about what we're going to talk about today. So what I'd like to do is go over this, and then we'll go over the list of the medications, and then I have at the end a little brief scenario that each clinic can use as kind of a mock code kind of situation. We used to run mock codes, but with it being so large now, having so many clinics, it's kind of hard to do that. And in fact, we used to, when we were just in the Dothan location, we used to call it a call doctor. So if there was a code, a page would go over that was call doctor to treatment room A or B or whatever. But obviously with the situation that we have right now, it's a little different with that. So it's going to be one of those situations where the doctor or the nurse will go into the treatment room and then just have a team of folks come in to kind of help out if a patient is in that kind of a situation. And so that's one of the benefits of, obviously, what we do. We've grown so much over the years, but at the same time, it makes it a little bit difficult to go to each clinic and do one of these situations. So that's why we're doing it now with the video. And like I said, I did want to have a kind of a mock code situation at the end where everybody can kind of get together in their own clinic and practice. First thing I want to say is thank you to each one of you all for what you do. I think we have the greatest jobs in the world. We get to take care of kids and help with families, and we just make such an impact on people's lives. And most of the time we're going to be seeing kids that are in pretty good shape, but occasionally a kid will get sick, and it's very important that we're trained and prepared to handle those emergency situations. Most of the codes in our office are going to be respiratory in nature. Now, one thing I will say as a caveat to that, though, is that we do have a subspecialty clinic now, and so we're going to be getting patients from all over the region, patients that we may not know very well, and patients that may have more serious issues going on. We now have a pediatric cardiologist that comes down every couple of weeks. We have a pediatric pulmonologist, a pediatric neurologist, and we're hoping to have a pediatric endocrinologist and a pediatric gastroenterologist in-house here real soon. So that does add to the level of complexity where it may not all be a respiratory kind of a case. It may be a kid with a congenital heart that's seeing a cardiologist that may have a cardiac issue. So it's important to be familiar with all the drugs, not just the respiratory medications. Everyone has to play a role. It's real important that you stay calm yourself during a code. There's a book that says that the third rule in the house of God is to check your own pulse when you're going into a crash cart situation or a code situation. So it's really important to remain calm yourself. Usually, of course, the doctor or the nurse practitioner is going to take the lead, but we need the nurses to be there. We need them to be in a calm situation as well, so that we can all kind of handle the situation in an effective manner. Someone needs to go ahead and call 911 right away. We obviously are blessed that in most of our clinics we're pretty close to a hospital, but there are going to be some times where we're going to have to get the patient stabilized in the clinic before they're able to get to the hospital. And you never know, there may be, a situation where the ambulances are all out, doing something, and we have to get that kid stabilized until the ambulance can get there. But it is important to go ahead and call 911 right away, so we can get emergency services there, so we can get the patient stabilized and get them to a hospital to be further cared for. It's real important that we get as much information about the patient as possible. Like I said, we're going to be getting patients in the subspecialty clinic that may be new to our whole system. So it's real important that we get information from the parent or the guardian about, are there any kind of chronic medical issues, what medications is the patient on, those kind of things. It's real important for pediatrics that we try to get a weight established right away because all the medications are going to be dosed based on the kid's weight. We need to know if the kid has any allergies, because we don't want to give anything that the patient may be potentially allergic to and then make a respiratory situation all of a sudden an anaphylaxis situation. Being familiar with the location of the emergency equipment is one of the most important things a nurse can do to be prepared in a code situation. For example, each one of these is going to be in the treatment room, but the oxygen tank may not be attached right to the crash cart in Ozark like it may be in the Dothan office. So it's really important to know that the where the oxygen tank is. It's important to know where the bags are. If we're going to have to be doing any suctioning, it's important to know where the suction apparatus is. The other thing I think that's important to know about that is, of course, we're a pediatric clinic, But every single day, there are going to be adults in the clinic as well, because they're not coming to the clinic by themselves. And there may be a situation where we may have to use the AED. And so it's really important to know where that is as well. The good thing about the AED is that it pretty much talks you through the whole process. But there are some subtle things that you need to be familiar with it. For example, if we're seeing an adult, now chances are we're going to try to get that adult out of our clinic right away. But if there's one of those situations where we need to try to go ahead and do the AED, if an adult is in the clinic and that person has hair on their chest, that hair has to be shaved off. We can't just go sticking electrodes on and shock the patient without cutting the hair off. So there's some subtle things you need to be familiar with the AED as well. So you may want to just take a moment to look through that as well. Drawer number 1 in the crash cart has the inventory list. It basically talks about all the medications we have in our crash cart. It has a Broslow tape and a drug book. The Broslow tape is real important because it's a tool that you can use, if it's a really bad situation, everything's going real quick and you don't have the patient's weight, then you can use the Broslow tape to use to estimate what the medication doses are going to be. It talks about what size ET tube you want to use and that kind of thing. So you just lay it out beside the patient in their different zones based on the length of the patient, where you can come up with the doses of the medicines and the ET tube sizes based on that patient's length as they stretch out on the exam tape. Drawer 2 is going to contain medication commonly used in a code situation. Drawer 3 contains IV access supplies, and drawer 4 contains items needed in airway maintenance, including oxygen masks, tubings, ET tubes, and suction catheters. As far as the ET tubes, I think it's really important that nurses get familiar with how this attaches, as well as the doctor needs to be familiar with it. So it's really important that you know. There's nothing real scientific about it, but you need to make sure that you know that it attaches a certain way. And so you just get it on there like that, and the light shines, and the doctor will use it to intubate the patient if necessary. But nurses may want to be familiar with how that attaches, so that if we're in a situation where the doctor's got something going on and he asks to intubate the patient, he asks you for the for the laryngoscope, that you can go ahead and put it on there for him, so that it maybe can make the situation a little bit smoother for everybody. But we have the ET tubes and the suction catheters and all that in that drawer. And then in drawer 5, we have all the IV supplies, and then we have the ambu bag for bagging the patient. It's real important, speaking of that if we're in a really bad situation where it is a cardiac arrest, that we realize that, sometimes we get excited and we get the ET tube in there, and we're, really happy that it's in. We check placement. Well, we got to realize that it's in, but we got to bag the patient. So you got to make sure that you understand that. Or if we give a medication, it's important. The heart's not working, it's not going to go anywhere unless we're doing CPR. So it's really important that we're sitting there giving compressions to make sure that the medication is getting to where it needs to go. So again, one of those situations where you need to keep your head about you and be calm and just make sure we're doing everything the right way. The patient's age and weight are very important, as we talked about before, in terms of knowing exactly what dose of medication we're going to give. A little formula that we can use, say you're getting a situation and you think, oh, this is a kid that, the Broslow tape may not be completely accurate because the patient has some kind of congenital problem, and sure, they stretch out this length, but this kid's really not that big. Or just the opposite way around. You can calculate an estimate of the kid's weight by going the age in years times 2 plus 10. So if you have a 2-year-old kid, that would be an estimated weight of about 14 kilograms. So age in years times 2 plus 10. Okay, so what we have in here is our medications. And of course, nurses are real familiar with giving albuterol, so you're familiar with its use and where we usually keep it. But albuterol is used commonly in asthma attacks to open the airway. Be familiar with some of the potential side effects of the medications as well. Albuterol may cause some tremor or headache or tachycardia. We have the ammonia inhalants for our teenagers that get HPV vaccine as they check out and they pass out at the checkout desk. That's just a joke. But we do have ammonia in those if we need it. Ativan is a medicine that we'll use in status epilepticus. It's given in an IV dose of 0.05 to 0.1 milligrams per kilogram and can be repeated every 10 to 15 minutes. And so it's right here in the cart. Lorazepam, actually, I'm sorry, is kept in the refrigerator. So that's another one of those situations where you need to know, okay, that's the medicine that we need to keep in the refrigerator. It's not going to be directly in the cart, so you need to know where that is at all times. Atropine sulfate is used for bradycardia and unresponsiveness and unresponsiveness, but we need to be familiar that it can cause some respiratory stimulation, and that's where it is right here in the cart. It can also be nebulized if we have somebody that's having some respiratory distress. We can nebulize atropine in 2.5 milliliters of normal saline for bronchospasm. But again, its main use is going to be for bradycardia or unresponsiveness to cause some respiratory stimulation. Benadryl is a medicine that, of course, is used for anaphylaxis, and it's dosed 1 milligram per kilogram. Dextrose is used for hypoglycemia, and it's dosed 2 milliliters per kilogram. The rectal diastat or Valium is used for seizures, and it's dosed 0.5 milligram per kilogram. It may be repeated every 5 minutes if results are not achieved with the first dose. Dilantin is actually a medication, and it's real important when we talk about these medicines to know which ones have to be given IV, which ones can be given IM, and which ones can be given through an ET tube. And we'll go through a mnemonic in a minute that talks about the ones that can be given through the ET tube. But the Dilantin IM, the phosphatonin, can be given IM, and it can be used in status epilepticus at a dose of 15 to 20 milligrams per kilogram. We have different forms of epinephrine, which of course we're using to increase the heart rate. We also have the EpiPen, and the EpiPens, a lot of patients have those already on them for anaphylaxis, but we do have those in the crash cart. The epinephrine in the 1 to 1,000 dose is used to increase heart rate and may be given via the ET tube and bagged in every 5 minutes. It's dosed at 0.1 milligrams per kilogram. The epinephrine 1 to 10,000 is dosed at 0.01 milligram per kilogram and may be given through an IV or an IO line. And each one of the carts will have an intraosseous needle in the future. And of course, the doctors will be the one to do that, where we go into or IM is intramedullary, and it's given. It's basically a needle that'll go into the tibia, and then you can use that to give medications just like you would in an IV situation. EpiPen Junior is for kids that are less than 30 pounds, and EpiPen, the regular EpiPen, you have to be over 30 pounds. And of course, that's given IM. Glucagon is used for hypoglycemia in children over 2 years old and can be dosed 0.1 to 0.2 milligrams per kilogram. It can be dosed repeatedly every 15 minutes as necessary. The instant glucose is used for hypoglycemia in children and under 2 years of age, and is dosed 1 to 2 milliliters per kilogram. Okay. Lidocaine, the 1% lidocaine may be given via the ET tube, and it's dosed 1 milligram per kilogram. It may cause bradycardia or respiratory depression. It's used for tachyarrhythmias like VFib. Unfortunately, of course, we won't see a whole lot of that in the pediatric situation, but again, we will be having some heart patients going through the specialty clinic, so you never know when you may have to use something that you never thought you'd have to use before. Narcan is used in narcotic overdoses. It may be given via the ET tube, and it's dosed 0.1 milligram per kilogram. And I just heard today on the radio program that high schools are now keeping Narcan stocked up. You'll hear about police officers that are keeping Narcan on them because there's so many folks that are having problems with opioid addiction. So it's kind of scary, but it is what it is in 2018. And then we have the IV fluids in the bottom. Normal saline is what we're going to usually give as a bolus for dehydration, and we usually dose that at 10 to 20 milliliters per kilogram. Phenobarbital, of course, is going to be here again, I'm sorry. It's used for status epilepticus. That's usually if we're having a seizure in a little baby that's lasting for more than 15 to 20 minutes. It's only given IV, and it has to be dosed at 15 to 30 milligrams per kilogram. We have to really monitor a patient if we're loading them up with phenobarbital because it can cause some respiratory depression. Sodium bicarbonate is used for metabolic acidosis. It'd be rare for us to have to dose that in a clinic. Usually those are going to be for patients that we know are acidotic, so we tend to want to have labs before we give sodium bicarbonate, but it's dosed at 2 milliequivalents per kilogram. Sodium medrol we use in anaphylaxis and respiratory codes. It may be given IM, and it's dosed at 2 milligrams per kilogram. Again, the IV fluids are in the bottom, and that's this normal saline, the D5 normal saline, and the D5 that we have, D5 water. Again, it's important to be familiar with the dose, the route of administration, and possible side effects of these medications. Lean, L-E-A-N, can be used to help remember which drugs can be given via the ETT. That's lidocaine, epinephrine, atropine, and Narcan. Again, remember that nurses are the most useful in a cold situation when they remain calm and work with the physician as a team to make sure that we have a good outcome for the patient when they come in a cold situation. All right, and then I have a little scenario. Obviously, we don't have the patient here, but we can kind of talk about a situation that I think is a pretty plausible case that may come up. This is Bebe Infermo. At 2 weeks of age, Bebe Infermo was diagnosed with a coarctation of the aorta. He came in for his 2-week checkup, and the doctor heard a murmur and didn't feel femoral pulses. He had an emergency echocardiogram at Flowers Hospital, and he was diagnosed with the coarctation of the aorta. He had a life flight up to Birmingham, and at 4 weeks of age, he had successful cardiac surgery. At 7 weeks of age, he was in to see Dr. B for what the mama thought was seizures, and Dr. B was concerned that maybe baby Infermo was indeed having some seizures. He called Vanna over at our subspecialty clinic, and she worked him in to see Dr. N right away. Dr. N, when he was doing the evaluation, heard wheezing throughout the chest and thought, well, this is a little bit odd. Let me have Dr. P come and see. And so Dr. P came in and said, this baby doesn't look good at all. Let's get a pulse ox on the baby and get a SAT. And the SAT was 82% on room air. So Dr. P decided, let's go straight to the treatment room and get this baby resuscitated. He ordered an albuterol aerosol treatment, and everybody knows where that is, and supplemental oxygen. So again, it's important that we know where our oxygen tank is. So in this situation, we need to get the baby started on oxygen. At this point, Dr. P said, this is not a good situation, someone call 911. The baby began to worsen as it got the breathing treatments, and Dr. P ordered the nurse to give him a 4.0 ET2. So it's again important to know where this is. So this is going to be in our respiratory drawer, and we have different sizes. We have a 3.0, a 4.0, a 5.0, and a 6.0. And so he orders a 4.0 ET2 and intubates the baby. He checks for placement, and the ET tube is taped in. Of course, somebody is going to start to bag the baby because now we have the baby intubated. Dr. C just happens to be in clinic that day, and he's walking by and he hears the commotion. He said, what's going on in the treatment room? And they said, that's Bebe Infermo. He's having some problems. And so he recognizes that name from when the baby was up at Children's having heart surgery, and he goes in and he does an EKG. Now obviously that's not going to be a situation in the regular clinics, but in the subspecialty clinic that may actually happen. He can do an EKG. He said, oh, he's having a tachyarrhythmia. He orders 5 milligrams of lidocaine to be given via the ET2. And again, lidocaine being one of the medicines that can be given through the ET2, he orders that to be given through the ET2 for the tachyarrhythmia. In the meantime, Nurse M gets an IV. And Dr. P then decides to order a bolus of IV fluids because his baby is not looking good. So he orders 100 cc normal saline bolus. Again, I didn't mention it earlier in the history, but when the baby was in the clinic, they did get a weight, and it was 5 kilograms. And so that's why these doses are the doses that I'm giving. And sure enough, in the meantime, the baby does start having seizures. The seizures last for about 15 minutes, and Dr. N decides to order 125 milligrams of phenobarbital, and it's given IV because Nurse M has already gotten an IV for us. In the meantime, EMS does arrive, and the baby is transported over to Flowers Hospital, where the baby is diagnosed with pneumococcal sepsis. The baby has successful treatment and is doing great. But that is a code situation that you can use where you can get familiar with different medications. In that particular situation, we did have to use the ET tube and get the baby intubated. We did have to give oxygen. We did have to give breathing treatments. We did have to give lidocaine, and we did get an IV and give phenobarbital and a loading dose. And of course, we worry about phenobarbital causing respiratory distress, but the baby's already got an ET tube, and we're bagging the baby. So it's a situation where we are monitoring the baby pretty closely. Unfortunately, in this particular case, EMS did arrive pretty quickly, and they got the baby taken to the hospital where he got successful treatment. But that's just a mock code situation that each clinic can use in the future, where the nurses can go through and actually grab the particular medication that the doctor ordered, and you can use that as a situation, as a learning experience. But thank you for your attention. I am so glad this is over, and bye-bye.